Welcome to the On Your Mind podcast, where we believe mental illness can be temporary and transformative. Stay tuned for innovative, effective tools from experts in the field of mental health. Hosted by Timothy J. Hayes, psychologist. This podcast aims to change the narrative around mental illness. Move from a place of fear to a place of hope and solutions. Here on Your Mind.
Dr. Mark Horowitz is a training psychiatrist, having done part of his training in Australia and now working in London as a clinical research fellow in the NHS. He is an honorary clinical research fellow at UCL. He has also completed a PhD in the neurobiology of depression and the pharmacology of antidepressants at the Institute of Psychiatry, Psychology, and Neuroscience at King's College in London. He learned after taking antidepressants for 15 years that it was extraordinarily difficult to come off of them, and he experienced a number of severe symptoms that were nothing like any of the symptoms that led to him taking the medication in the first place. His research led him to discover nothing like what he had been trained in his medical training or his psychiatric training. So he authored a paper about how to come off antidepressants based on the neurobiology of their actions, which was published in the Lancet Psychiatry, and it was widely reported. Since then, he has worked to communicate to psychiatrists, other doctors, and the public how to safely taper off antidepressants and other psychiatric medications. He currently works with the Outro Health clinics in London and the United States, a virtual clinic providing patients with safe antidepressant tapering services based on the process of hyperbolic tapering. Well, Dr. Horowitz, thank you so much for joining me today. It's a delight to see you face to face.
Thanks for having me on to talk about this important topic.
I'm hoping you can let us know a little bit about how you got started in the work you're doing and what drives your passion for it.
Sure. So, all my work now is about helping people to stop psychiatric drugs. And I guess the reason that I came to that is because of my own trouble coming off psychiatric drugs. So I grew up in Australia. I trained as a psychiatrist there, and I came to England to do a PhD in how antidepressants work. And at the end of my PhD, I read a paper about withdrawal effects from antidepressants, which I found quite startling because at that point I'd been on an antidepressant for 13 years, and I had a lot of health problems while I was on that drug, and I had considered stopping it, and this idea of the drug causing withdrawal effects kind of pushed me over the line, and I decided to try to come off. And I read everything I could about how to come off these drugs from the academics that I was working with at the time in my PhD, and they all said it was very easy to come off. The papers said that there was mild and brief withdrawal symptoms. You could come off in a few weeks. I also checked online, and people talked about having huge trouble coming off. It took them months, years. They were grinding up tablets with knives and nail files and measuring things and making liquids and having all sorts of trouble coming off to the point where they were being admitted to hospital. And I didn't really know what to take, what to trust. And I sort of decided to split the difference. And I came off my drug, which was escitalopram or Lexapro. I came off it over 4 months. I used equipment from the molecular biology lab that I was working in at the time, and I halved my drug about every month. And when I got down to 1 milligram of my drug, which was a very low dose, much lower than any tablet that you can get in America or Australia, I had terrible symptoms. My life really imploded in many ways. I had trouble sleeping. I'd wake up in the mornings in full-blown panic, like I was being chased by a wild animal. My palms were sweating. My heart was beating. I would be in a state of terror or panic, and that would last for 10 or 11 hours of the day. I took up sort of running. I was running until my feet bled, basically. I was meditating. I listened to John Kabat-Zinn's body scan meditation probably a couple of thousand times in a few weeks. I felt dizzy. Things around me appeared kind of unreal, dreamlike. Um, it was really the terror, the panic that got to me. And after a few weeks of that, I thought, I don't think I can keep living like this. I thought for the first time in my life very seriously about suicide. Um, and I guess the first thing I should say is that that was nothing like the issues that had put me on the drug in the first place. I went on this drug when I was 21. I was a miserable young man. I was very unsure about my career, unsure about my university course. I hated medical school. Um, I'd had some experiences growing up with bullying. I had a whole set of, existential issues. I was miserable. I was pessimistic. Um, but what I had then was nothing like what I had when I came off these drugs. It was a completely different set of symptoms, different severity. What I'd had when I came, if what I had when I went on the drugs was 3 out of 10, what I had when I came off the drugs was more like 10 out of 10. Um, I eventually decided that I must go back on the drugs because I was in such a terrible state and my symptoms eventually settled down. And at that point, I understood that I was not on these drugs because they were helpful to me anymore. I was on them because I was unable to stop them. So I was trapped on the drugs. And I guess um, for a while, I thought, oh, well, I'm a very unlucky bloke. I've just had a very hard time coming off these drugs. It's just me. But I very soon found that there were hundreds of other people with similar problems. And then I found thousands. And eventually I found tens of thousands of people on online forums, chat rooms, anywhere you could put down comments talking about the trouble they had coming off antidepressants with extremely similar symptoms and circumstances to me. And I thought, the professors that I worked with who were saying this is no trouble at all, either don't understand or something else is going on here. And I now, about 5 years ago, I basically switched to this being my area of research and practice. And I've set up a clinic in London to help people come off antidepressants, done a lot of research on it. And I, over the last few years, have come off my drug. So after that time I've just told you where things went disastrously wrong, I came back now 5 or 6 years ago and decided that I knew who the experts were. It was the people on these online forums, and I followed their guidance. So I sort of, slightly strange circumstance, I have 6 academic degrees. I have a PhD from the institute in the world that's most cited for psychiatry, the Institute of Psychiatry in the UK. But I was taking advice on how to come off these drugs from people on online forums. Basically, a retired software engineer called Adele Framer is the person that taught me most about this, despite all my formal training. And so I've spent the last few years trying to communicate those ideas to other doctors, to the government, to the public health system, and to patients, to let them know that there are easier ways to come off these drugs and to alert people to the harms of these medications in general.
It's powerful, powerful. And the idea that most people who are getting these drugs from a psychiatrist or a primary care physician, it happens a lot. I interviewed somebody who was from Australia who was very alarmed that Australia was adopting the U.S. model for healthcare so that the primary care physician was going to be the gatekeeper for a lot of these psychotropic drugs and giving them to younger and younger kids. And the fact that the people giving these drugs are getting their education about the drugs from the people who make money off the drugs is alarming. And so many of them don't have good information to give their patients, like you're saying, when they want to come off of it, or even they're not even able to give a robust, informed consent.
Yeah, I think that's true. I think some, if there are doctors listening, they might find that strange to hear that they're getting their education about the drugs from the people that make the drugs. They'll say that doesn't sound familiar to them because people don't go to Pfizer or AstraZeneca or Janssen to get education about these drugs. They go to their medical schools. They go to lectures by famous professors. Maybe there's more understanding that a lot of what is being taught is sculpted by drug companies in lots of different ways because the studies that are published are conducted by the drug companies. Many of the top professors in the field are paid by drug companies, and that influences what they say. Those professors often set exams and curricula. So I remember being very shocked. I mean, Australia is probably not quite as commercially captured as America is, although we're not that far behind. I remember being shocked when I found out that the head professor at my Institute of Psychiatry in Australia, was a very highly paid thought leader by drug companies, and the same in the UK, that the head of my department was someone who'd been paid particularly to talk down the risks of withdrawal effects from antidepressants. I remember reading books like that and being, I thought I'm a very savvy consumer of medical information. I'm cleverer than the average bear. I know how to spot, a fast one. But I realized that I had no idea that I was a lamb going to the slaughter, because I just hadn't realized how embedded some of the key academics were, and how much guidelines are affected by the kind of studies that drug companies produce. So I think someone described it to me once as it's essentially doctors are essentially walking through a stage managed theatre set where they think they're getting different opinions, and this is critical, but really a lot of it is set out by drug companies, studies, thought leaders, guidelines. And so, yes, I think they do have a big influence. And as you say, that comes to the crux of the issue is, I think that almost nobody has been given informed consent, or has given informed consent for starting these drugs, because I learned about these drugs, what they really do, 15 years into taking them. I have certainly not been giving informed consent to my patients before I understood these things.
So
Now I'm not.
did you say you were taking them for 15 years before you decided to stop?
Exactly. I was taking them for 15 years 13 years the first time, and the second time I was taking them for 15 or 16 years. So I was, I spent a lot of time on these drugs without understanding what they were doing, because I had never really been, yes, I'd never been educated as to what their issues were, or what harm they can cause.
So is there a way with all of the research you've done to this point to talk at a layperson's level of understanding about why it would be so difficult to come off of these things? We have people who say, well, look, here's the half-life of the drug. That drug is out of your system in X number of days. So that can't be causing the problem. How do you understand the actuality of that these days?
Yeah, it's a really key point you bring up. So, the reason why psychiatric drugs are hard to stop is the same reason as any drug is hard to stop. When we take a drug, there's the principle of homeostasis, which means that our bodies want to stay in the middle. When it's too hot outside, we sweat. When it's too cold outside, we shiver. The body is always trying to push back against any change to our system. And so when you take a drug like an antidepressant that increases levels of serotonin abnormally in your synapse, your body becomes less sensitive to serotonin. In the same way as when you drink caffeine, your body becomes less sensitive to caffeine over time. The same thing happens to psychiatric drugs. And now when you reduce or stop the drug, your body is screaming out for the drug to come back, because it's so accustomed to it, like you get withdrawal from caffeine or heroin or cigarettes.
Because there's actual physiological changes in our bodies to accommodate this extra substance that's being put in there.
Exactly. Our body is reacting against it to make it have less effect, to try to sort of diminish changes to its system, to maintain its balance. Exactly. And then, so the drug is leaving your system, and your body is starting to miss it, and it's starting to be disrupted by that and screaming out for the drug, which is what withdrawal effects are. And then you raise a really important point about how long these withdrawal effects can last for. So the average doctor will say, well, these drugs leave your system in a few days or weeks. After that, it can't be withdrawal anymore. But they have misunderstood what causes withdrawal, because, of course, it is the drug leaving your system, but it's the difference between what your brain and body expect and what the drug is giving to you. So it's how long it takes your brain and body to become used to the drug not being there that explains how long withdrawal effects can last for. And what we know from brain imaging is that after people have been on antidepressants for months or years, there are changes to their brain that can persist for up to 4 years after stopping.
Wow.
We see that in animals as well. Animals have changes to their hormonal system and their serotonin system for more than a year after stopping antidepressants they've been taking for only a few weeks. In other words, they can leave a very long effect on the brain. And that's why we think withdrawal effects can last so long. I'll just give you a quick analogy that I often give, which is if you go into a loud concert, your eardrums become less sensitive to sound. And if you go into the quiet street, your friends' voices sound muffled for a while. It's actually a sound withdrawal syndrome. Now, the time for the sound to go away is a second. When you shut the door to the concert, it's gone. The reason why it takes a couple of minutes for the voices around you to sound normal is because your eardrum takes a couple of minutes to relax. In other words, the adaptation to the stimulus takes longer to relax than the stimulus takes to disappear. The same for psychiatric drugs. Days or weeks to leave your system, but months or years for the effects on your brain to dissipate. And that's why you can have such long effects, we think.
Yeah, it reminds me of years ago in my internship, a gentleman came into a regular AA meeting, and he was clearly in his 60s and an old timer, and everybody celebrated him being there. But when they went around to tell the story, he says, "Hey, so why are you back?" He had been sober 35 years, and he'd been out helping somebody in a garage on a hot summer day, and the guy said, "You want something to drink?" And he said, "Sure, I'll have Pepsi or whatever." He said, "All I got's beer." So he said no for the first 4 or 5, offerings. But as the day wore on and it was hot, he said, "What can it hurt? I've been sober for 35 years." He said he had a beer and he woke up 4 days later. So his system was like right back at that addictive, I've got to have more of this, I'm flooding. And the essence of his belief is he picked up right where he left off 35 years before with the addictive process, with his body having needing more of the substance to have any kind of a buzz effect.
Yeah. I'll just say one thing about that. There's one difference between alcohol and antidepressants, which is antidepressants aren't addictive. No one is snorting antidepressants or trying to get more or stealing from their neighbors or selling their body to get antidepressants. What's important for antidepressants is they cause physical dependence. I think the words dependence and addiction, people mix them up in popular culture and in medical textbooks. But physical dependence just means you get used to the drug and just by using it every day for several weeks or months, and when you stop it, you get withdrawal from it.
Or you build a tolerance for it.
And you build a tolerance to it. You don't need to be, naughty to be a bit glib. You don't need to be abusing it. You don't need to be misusing it. There's no craving. There's no compulsion. And none of that's relevant to antidepressants. You don't need that. I'd sort of compare it to, say, caffeine. I'm sure that you and everyone in the audience drinks caffeine. No one is snorting it, stealing it. But if you stop caffeine, you get a withdrawal syndrome. So you don't need to be addicted. You just need to be using it over time to get physical dependence. That's where alcohol is somewhat different from antidepressants.
But also similar in the way that the body makes adaptations to be able to remain functioning under higher and higher levels of that substance, whether it's the antidepressant or the alcohol or the cocaine or whatever. And then when it's not there, the functioning of the body doesn't work so well because it's got physiological changes to accommodate something that's now not there.
Yes, exactly. So I should say substances that are addiction always involves physical dependence. So antidepressants, caffeine, benzodiazepines, alcohol all cause physical dependence, but alcohol and benzodiazepines particularly also cause addiction. So physical dependence is a necessary condition for addiction. So you're right. So yes, exactly. That's where the overlap is. That's a fair.
Yeah. It's amazing. The other thing that came to mind as you were talking is that over the last 5 years of doing this podcast, I've interviewed a number of psychiatrists that got their medical training and got out ready to match a list of symptoms with a list of drugs they could prescribe. And then they ran into the information that you're putting out and that Robert Whitaker puts out in his book, Anatomy of an Epidemic. And And then they were horrified that they hadn't been taught any of this in their training.
Yeah, I think a lot of psychiatrists who encounter this sort of information don't want to hear it because it's very, it's very disturbing if you've got a sort of life going along on rails and you hear things that what you're doing is not very helpful to people or might be causing them harm. I think it's very confronting for doctors to hear. Most doctors want to do good, want to help patients and make a living. That's why they, why they do what they do. So it was certainly horrifying for me. I guess uh, I didn't have the luxury of having professional distance from it because it was very personal for me. I was, on both sides of the desk. I was a patient as much as a doctor. I guess I was a patient before I was a doctor in lots of ways. So I guess that made it had personal resonance for me. But yes, it is disturbing to sort of work out that you've been taught half the story or a portion of it or a kind of a cherry-picked version of the literature. It is definitely disruptive to someone's way of practicing.
And so currently you are working, you've created a clinic where people can come and get help getting off of these drugs with the least a disruption to their functioning. And can you tell us about that, how that came to be and what it's like for someone to come to your clinic these days?
So, there's actually kind of a couple of different clinics that I'm involved in. I run a clinic in London in the public health system in what we call the National Health Service that we set up now about 2.5 years ago, and it's to local people in the area, and we help them to come off, and I can talk about the process. The other clinic that I help run might be more relevant to some of your listeners because it's in America. I work with a group who now run a clinic called Outro Health that operates in California, in Colorado, and Washington State. And we do very similar things in my London clinic and the American clinic, or the American one is much more high tech and gee whiz because young, clever people are involved in it. And essentially what we do is we assess people, why are they on the drugs, have they tried to stop before, have they thought about the benefits and the harms, have they pursued alternatives, what are the issues that the drugs are causing, and very common themes come up, some of which are, most people start these drugs at a bad point in their lives, after a divorce, after a job loss, moving to a new city, things go wrong in their lives and they feel anxious, depressed, they go see their doctor and they're often given a drug very, very quickly. And sort of now, 5 years later, 10 years later, 20 years later, they're still on the same drugs. I've seen women with postpartum depression who their children are now 30, people who got divorced, then they're with another partner now, so sort of life has moved on. And so a lot of people think, do I really need to be on the drugs still? And they have all sorts of issues on the drugs. People have sexual problems. People have trouble with sleep that the drugs can often cause. They've got memory impairment that we know the drugs can cause, concentration issues. They have weight gain. One of the most common problems that people have is emotional numbing. They say they don't feel things fully anymore. And I think that's really, if it came down to it, I think that's the way the drugs really work. I think there are emotional numbing kind of agents. They turn your emotional range from very high, very low, they sort of squash it into the middle. And so I think when people say the drugs work for them, I can believe some people who say that. And I think what they're saying is, I was panicked 10 out of 10 and it was turned down to 3, and that was a relief. But in the long term, to have your emotions turned down 70% can have all sorts of, undesirable consequences. It can affect your...
And the key point here is it doesn't just turn down the emotions you don't like,
Yeah,
right?
exactly.
It turns them all down.
Yeah, exactly. So I think, these, when you hear the word antidepressant, it sounds like a targeted bullet, like some sort of heat-seeking missile just to get to the negative thoughts. But of course, we don't have anything like that kind of technology. It seems to be, much more crude. In fact, not just for the mind, but, we know that sexual numbing correlates with emotional numbing. And in fact, a lot of antidepressants, if you crunch them up and swish them around your mouth, they'll numb your mouth. So there is kind of an anesthetic flavor to these drugs, emotionally and physically. And that's one of the main reasons people want to come off them. They often say, I don't know who I am anymore. I don't know what I think about my husband, wife, child, mother, because I just lack, an inner sensitivity. I used to like art, I used to like sport, and I've just lost my interest in it. So that's a very big issue people have. Some people are concerned about the physical health problems. There are studies that link these drugs to almost every physical health issue: diabetes, obesity, cataracts, osteoporosis, heart disease, and even an early death. So there are all sorts of concerns about the long-term effects on people's health. Uh, and then people will say that they've tried to stop the drug before. Often people have tried, and they've tried by themselves, sometimes with their doctors, often pretty quickly. A very common way of stopping the drugs that doctors will recommend is halve the drug for 2 weeks, halve it again for another 2 weeks, maybe every second day, and then stop it. So people are off their drugs in a month or two. And doctors say, well, that's what the textbooks say. And most people find that incredibly hard. They end up in the sort of state that I was in a few years ago: panicked, anxious, miserable, brain zaps, headaches, dizziness, a whole host of symptoms. And that confuses people. Sometimes people think, is that my original condition coming back? Or is it withdrawal? And most doctors haven't been taught much about withdrawal. In my training, it was barely mentioned. The textbooks say it's mild and brief. So when someone walks into your office and they're in pieces, you don't really think about mild and brief symptoms. You think, gee, something else is going on here. It must be, a serious mental health condition. If I had walked into any doctor's office when I was in the state that I was in, it would have been a second for me being diagnosed with a mental health problem. And it's confusing even to patients. I guess for me, it was a bit clearer because it was so severe and what I'd gone on the drugs for was so different. But for other people, it can be very confusing. And I think one of the reasons it can be confusing is the emotions can be quite familiar. And I'll make a little point here. If both me and you sat down and drank too much coffee, we both become anxious. But you'd become anxious in a Dr. Hayes kind of way, and I'd become anxious in a me kind of way, because it's our minds through which the chemicals are being filtered. And the same is true for withdrawal from antidepressants. Although it's a chemical cause, if you worry about, the way you look, or you worry about work, you probably worry about the way you look and the way and work because it's your mind. And because of that, withdrawal effects can be very familiar, and that can also be confusing to people. So some people, are scared of withdrawal effects. Some people think that they've relapsed. And these are the kind of things that keep people on the drugs. And so we go through all of this, in people's histories to work out, where they are, what they want to do, and what they've tried in the past.
And one of the biggest problems that I run into with people is that then the medical doctor will say to them, well, the fact that you're having such a hard time coming off this medication is an indication that you needed the medication.
Yeah.
That you're going into a relapse for whatever the mental health issue was that they gave you the prescription for in the first place, rather than recognizing it as withdrawal effects.
Yeah. So it's a huge issue. We know that happens to thousands, if not millions of people. It's because, medical education talks about relapse, 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 doesn't mention withdrawal. And so all doctors are very focused on relapse. We know that there's overlap in the symptoms, which makes it very easy to make the mistake. But it's generally the wrong. I should say, in my experience, withdrawal is the horse, and relapse is the zebra. They say in medical school, when you hear hoofbeats, think of horses, not zebras, because horses are much more common than zebras. And most doctors have been taught that relapse is the horse, and withdrawal is the zebra. In other words, withdrawal is rare. But I think the data says something very different, because, first of all, I think relapse, which is the technical term for a return to someone's underlying condition, doesn't make a lot of sense for most people. Most people who go on antidepressants were depressed when they got divorced, lost their job. You can't have a relapse of divorce. You can't have a relapse of losing your job, unless you're very unlucky. In other words, we're all capable of feeling depressed under enough pressure. And most people go to see their doctor at the worst point in their lives. Most people do not have recurrent severe depression. That's, very unusual. Most people, when things are bad in their lives, they feel bad. And when things are okay, they feel okay. So I like to say, life is a relapsing remitting condition, not depression. When life is okay, things are okay. So I think that relapse doesn't make sense for a lot of people, but withdrawal, we know from studies, occurs to about half the people who stop antidepressants. And the longer you're on the drugs, the more common they are. And so it's very easy to be confused, but I think most doctors are misdiagnosing withdrawal as relapse.
Well, and the other thing that people like Robert Whitaker point out in his book, Anatomy of an Epidemic, is that the pattern for depression prior to the advent of all these different antidepressants was people would get depressed, and with or without treatment, in about a year's time, they'd be over the depression for the most part. And then for the most part, they would not have recurrence off and on throughout their life. Oddly, since these antidepressants have proliferated and gotten so common, it's very common for people to have recurrence of the depression and the cycle of anxiety. And
Yeah. I think there's two possible things going on there. Number one is the issue we've just talked about. Are those recurrences, is that really about withdrawal effects from the drugs? People come off and they feel miserable and they think it's relapse. That's the first issue. And the second issue, I think, is, there's a sort of increasing area on what's called tardive dysphoria, which is a fancy Latin term for the drugs can make you miserable. And I'm that makes a lot of sense to me these days. I think it was certainly true for me. I was a lot more miserable on the drugs than I am off them. Now, taking out withdrawal, the withdrawal process can be difficult, but now that I'm being on the other side of things, and I think there's a few different ways that antidepressants can make people more miserable. I'm not sure which one is the most important, but a few of them are. Antidepressants disrupt sleep. It's very clear in every study, antidepressants shuffle sleep. They prevent slow wave sleep. They prevent REM sleep. Often people on antidepressants don't dream. I think that's probably why they cause daytime fatigue for many people, concentration issues, memory issues, and trouble with emotional processing. And so I think they can make people more emotionally labile. I talked about numbing, but I think there's another side of things where they can also make people much more up and down. And I sometimes see, I don't know how that fits together, but people can both be kind of numbed and also sort of inside, up and down. I don't quite know how that fits together, but I've certainly seen that kind of mixed picture. I found the fact that I was tired all the time, and my memory was a bit knocked off was very depressing to me. I'm a bit of an academic person. Like a lot of people, I rely on my brain, and that was very depressing. And then I also think there are some sort of direct toxic effects because, antidepressants act in a very similar way to MDMA or ecstasy, the party drug, not as strong, not as, doesn't, people don't take a bit of Zoloft and end up going to a rave party. But there's the pharmacology is very similar. And as is well known, taking MDMA every day is not good for your brain. It causes, all sorts of trouble. Well, I think it's quite plausible that a small dose of MDMA, which is what SSRIs are, is not very good for things in the long term. I think that might be one reason why people can get sicker and sicker on the drugs. And I think that was true for me when I look back.
well, and the other thing that you mentioned is that a lot of people have, as they're ingesting the antidepressant, their body gets acclimated to it, and so it doesn't have as much effect. And so they'll hit a stressful time in their life, go back to their doctor, and just get the dose increased. And
Sure.
over time, that's it clearly reaches a point of diminishing returns because I've worked with people that they've been back for bumping and let's add another medication and the polypharmacy that happens. Sometimes people on 4 and 5 medications by the time they come see me. And I say, I'm not anti-medication. And yet, if you're on 5 medications or even 4, and you're so upset and miserable in your life that you're coming to see a therapist still, but you've seen a therapist for years, something's out of whack. Something's not producing the results you need. And the
Yeah.
answer is probably not more medication.
Yeah. I mean, that's right. I think that's a fair thing to say. If the first 4 medications hasn't worked, it's very unlikely that the fifth one will. And I think that's, that gets down to a more central question, which is, I don't think antidepressants can solve people's life problems. People go to therapy, they're distressed because mostly of things going on in their lives, maybe uh, things going on in their childhoods. There's no drug that can fix those things. Americans were sold this line that depression is caused by a chemical imbalance that can be fixed by drugs. But of course, that's mostly nonsense. No self-respecting psychiatrist would say that anymore in public. The research doesn't back that up. What the drugs are probably doing is numbing people's emotions. That can't fix things. It can defer problems, it can squash them down, but it doesn't really solve anything. And so, I think these drugs can't solve these sort of conflicts in people's lives.
As I
Um,
was listening to one of your other interviews, I think I heard you say that there's some research that makes it clear that it's not very effective to bounce from one antidepressant to another. The
yeah,
idea of what we just haven't found the right one for you yet. Is there research that disproves that theory?
yeah. So that's right. So people would have heard this from their doctors. Maybe we've got to just keep trialing it until we find the right drug. The research says that doesn't work. So there is a meta-analysis. That's a study where they put together all the studies in an area to ask if someone doesn't respond to one antidepressant, do they respond to the second one? And there are 8 trials, 8 randomized controlled trials looking at that. And all of them are negative. That means that if someone doesn't respond to the first antidepressant, then they're not going to respond to the second antidepressant. So this idea that you just keep on cycling through them until you find one is not based on any evidence. Um, I'm most upset by seeing people waste years or decades of their life to look for the right cocktail with this idea that if you just find the right combination of drugs, everything will be okay. I think that's very misleading to people. I think they can waste years talking about side effects, this drug and that drug, and not really dealing with the core issues in their lives that are, that of course in their lives, in their relationships, in the ways they're thinking, in the way they're living their lives.
It sounds to me, it's my understanding that that's part of what was in the STAR D study. Are you familiar with the STAR D study?
I've got, yes, I understand it to some degree.
And that they were trying to determine, or ostensibly they were trying to determine how effective the antidepressants are in real world settings. And so they had a protocol that said you'd go to a psychiatrist and you'd get a medication, and if it didn't work, they would switch you to another, and the kind of thing that's actually happening out in real practice. The horrible problem with it is that the whole study was a hoax and that they fudged all the data and came out saying it's got a 70% success rate when they actually did the Freedom of Information Act and got access to the patient level data, they found maybe a 3% success rate in the long term. And so it's studies like that that get published and then people use as evidence. See, these are good medications. They help people with depression. But people who understand, if the investigative reporters look into it, they understand there aren't any good research results on long-term success with the antidepressants.
Yeah. So I think that's probably I don't think the study was fudged, but you're right. They did make changes in the way they reported it that made the study look a lot more favorable for the drugs than it was. But you make some very good points, which is I think most people don't recognize that 97% of all antidepressant studies go for 12 weeks or less, which means that most people who are walking around the drugs for years or decades, like I was, we're basically, I was part of a massive experiment because the studies have not been done. We're living the experiment. So you're right, we don't have a lot of data on the long-term effects of the drugs. Um, what we do know, and you mentioned it before, is, natural recovery, because in the STAR D trial, one of the major issues with it is there was no placebo arm. So we don't know what would have happened if people were given no drugs. In other studies, like you mentioned, after a year, 80% of people are better, even for very severe depression. In other words, people recover, they change, life moves on, they come back to their equilibrium. So there's lots of things that happen other than drugs having an effect. And So you're right. The long-term effects are kind of unknown. I think they're being played out in real life, and I think a lot of the problems that I see, are not documented well because of this focus on short-term studies, and so there are big question marks over the long-term health of people on these drugs.
Well, people can find out more about that on the Mad in America website, Robert Whitaker's work, and you can just go there and type in the STAR-D study and get all kinds of information on that. I'd like to have you return to what is it that people get when they come to the clinics you have either in the UK or in Colorado, California, or Washington State?
Okay, so I talk about the assessments, and maybe I'll talk about then if people decide. So we will explain to them. I sort of feel that part of our job is actually giving people informed consent. They might be they're already on the drugs for 10 years or more, but that's we explain to them what the benefits of the drugs are. We show that they are really they're minimal. I show them graphs of what the drugs do compared to placebo. It's very you need a magnifying glass to see the difference. Talk about the harms, ask them what they've experienced, talk about withdrawal effects, talk about alternatives. And if people make an informed decision to want to stop the drugs, then we help them to stop. That's the main thing, of course, that we do. And there are three major principles that we use to help people come off their drugs. The first one is we do it slowly. And I've heard a lot of doctors say, oh, I do it slowly too. Everyone does it slowly. But I think what slowly means, in my terms, is different to what most doctors say. Slowly in my book means months and sometimes years to come off the drugs. So I should say it's taken me years to come off my drugs because it was so unpleasant. We know that there are studies that show that people who take months or longer have a much better time of it than people who come off in weeks or less. And so a rule of thumb might be something like 10% of your dose every month. Where when you're on 100 milligrams, that means about 10 milligrams. When you're down to 20 milligrams, it means about 2 milligrams a month. So the first principle is slow. The second principle is you've got to go at a rate that you can tolerate. There's not enough research to be able to say, look, this person, Mr. Blog's been on it for 10 years, effects sore, tried to come off 3 times, he should take 18 months. We don't have enough of that evidence yet. I'd like to contribute to that, but it's not there yet. And so there's a little bit of trial and error. You make a small reduction. How does somebody respond? If they're okay, keep going. They get into trouble, go back, pause, go down more slowly. I think of it a bit like an analogy might be altitude sickness. I think it's a good analogy for withdrawal effects. If you go up in a mountain too quickly, you get altitude sickness. It doesn't mean you can't go to that altitude. It just means you need to go more gradually. So you might need to go back, recalibrate to that level of air pressure and then do it again. I think that's exactly the same with coming off these drugs. You've got to do it at a rate. Withdrawal effects is kind of a feedback. You're going too quickly. If you have them, it doesn't mean you can't come off the drugs. It means you need to go more slowly. You need to go back, recalibrate, come off it more slowly. So we do a lot of that. And eventually people find a rate, 10% per month, 8% per month, 15% per month. People find what suits them. The last point to realize is, so this is an example of citalopram or Celexa, very commonly used in America. It's brain imaging. And what it shows is dose of this drug on the x-axis and effect on the brain on the y-axis. It's basically effect on serotonin. And the key point is it's not a straight line. So that going from 20 milligrams to 40 milligrams isn't doubling the effect on the brain. It's doubling the dose, but not the effect. And even a tiny dose like 2 milligrams, because the smallest tablet in America is 20 milligrams, so 2 milligrams, most doctors might laugh at that. Even 2 milligrams actually has about half the effect of 60 milligrams, much bigger than people think. And basically the reason for this is when there's not much drug in the system, all the receptors are open for business. And so every extra milligram of drug has a big effect. As there's more and more drug, it has less and less effect because a lot of the receptors are occupied. And that tells us what happens when most doctors give advice on how to come off the drugs. So they would say, let's go down from 20 to 15 to 10 to 5 to 0. Kind of seems intuitively appealing. It's quite simple to do with tablets.
Right.
The problem with that, though, is The first reduction is often okay because it causes a small change in effect on the brain. Next one's a bit more difficult. From 10 to 5 can be more unpleasant, but from 5 to 0 is like jumping off a cliff.
Right.
It has a huge effect on the brain, and people really suffer in that, and they can end up, in a complete mess. And most doctors don't understand this relationship. So what makes more sense is to come off the drug in a way that reduces the effect on the brain by even amounts, like this. So I've drawn 4 horizontal lines here on effect on the brain. And that means you need to go down by smaller and smaller amounts, down to very small doses before stopping.
Right.
So that final step down isn't a big jump. So it's sort of like, imagine this is walking down a path, starts off easy country walk, turns into a hill, and then for the cliff bit, you need to go down step by step. And you basically can approximate this kind of reduction by reducing by about 10% of your dose every month. So it's getting smaller and smaller as you get down to lower doses. And this is called hyperbolic tapering, because this graph is a hyperbola. And that's what I do in my clinic in America and in the UK. And an important part of that is it's very hard to get these small doses with using existing tablets. And that's why people are at home grinding up tablets and crushing them and making liquids. And we try to help people in the clinic by getting them liquid versions of drugs or very small doses with tablets or capsules to try to make life easier for people. So we guide them through this reduction. We give them support because, of course, there's always a little bit of upset. We're trying to make things as easy as possible for people. We give them other things to help them manage their mental health along the way. And in this way, people take a lot longer to come off their drugs than they did with their doctors, but they're much more likely to be successful.
Yeah, and I remember I interviewed Dr. Peter Breggin, and he wrote a book on coming off the psychotropic meds. And at least 2 of the points are just like the ones you made. One of them is that the biggest impression he wanted to make was it has to be patient specific. It has to be driven by the individual's experience, because that can be so dramatically different from one person to the next. And then the other thing is, as you're talking about, basing the reduction on a percentage of what's already, that the person has reached homeostasis with, rather than here, you're on 10 milligrams, let's cut it in half, and let's cut that in half. And based on the person's level of personal comfort, a percentage of that in small increments.
You've got it. Exactly. Yep.
Well, I wonder if you just take a breath and get centered and let me know here. We got just a few minutes left. What you'd like to leave the audience with? What's your biggest hope?
Good question. Look, I hope that more people in America and around the world, become better informed about what antidepressants do and what they can't do, and that they, might be for some people a bit of a short-term numbing agent, which might get people through, a difficult patch. But there's all sorts of consequences to their health in the long term. And having trouble stopping doesn't mean that you need to be on the drug, as you said. And that there are ways of coming off the drug that are much slower and more gradual. And I hope that, if we sort of move past what are a little bit fake fixes like drugs are, that people can focus on the more important things in their lives, which is, their relationships, politics of a country, very important today in America. And what are the things in society that make us, happier or less satisfied, and sort of stop this and move past this biomedical understanding of depression, which I think has been so harmful and so destructive to so many people's lives, and move to something more psychosocial, something more holistic.
Wonderful. Well, I couldn't agree more. It is the pleasure meeting you and to find out more about your work. If people want to reach out to you, how would you like to have them connect with you?
So I'm on Twitter at Mark Horrow, MarkHoro. I've got a bit of a dinky website at markhorowitz.org. There's a contact form. I get a lot of emails from people around the world asking me for advice. And I'm also working with Outro Health in America, if people are in those states, they might want to look at some support from Outro Health.
Wonderful. Well, thank you so much for taking time to be with us. It's delightful to meet you and to find out more about your work.
Thanks, Dr. Hayes.
Dr. Mark Horowitz is a training psychiatrist, having done part of his training in Australia and now working in London as a clinical research fellow in the NHS. He is an honorary clinical research fellow at UCL. He has also completed a PhD in the neurobiology of depression and the pharmacology of antidepressants at the Institute of Psychiatry, Psychology, and Neuroscience at King's College in London. He learned after taking antidepressants for 15 years that it was extraordinarily difficult to come off of them, and he experienced a number of severe symptoms that were nothing like any of the symptoms that led to him taking the medication in the first place. His research led him to discover nothing like what he had been trained in his medical training or his psychiatric training. So he authored a paper about how to come off antidepressants based on the neurobiology of their actions, which was published in The Lancet Psychiatry, and it was widely reported. Since then, he has worked to communicate to psychiatrists, other doctors, and the public how to safely taper off antidepressants and other psychiatric medications. He currently works with the Outro Health clinics in London and the United States, a virtual clinic providing patients with safe antidepressant tapering services based on the process of hyperbolic tapering.
You've been listening to the On Your Mind podcast, offered by Journey's Dream, where we support people through mental health challenges to a place of true and lasting well-being. If you love our show, we invite you to visit onyourmindpodcast.org to join the conversation, access the show notes, and discover our helpful resources. Thank you for listening.